Welcome to Medical Grand Rounds. It's a pleasure today to introduce a colleague from the Department of Surgery, Dr. Wayne Overby, who many of you may know. Dr. Overby is currently Director of Laparoscopic and Advanced GI Surgery, I think. If not, he got a promotion by coming to Medical Grand Rounds. He has a particular interest in obesity surgery and did special training here in laparoscopic surgery and has been one of the people who's advanced this for our community of patients and physicians. And today he's going to talk about morbid obesity and practical advice for advising patients. And I'd like to thank Dr. Overby for being here today. Thank you.
Well, thank you very much for having me. I guess I should start off by saying this is something I believe in. It's something I love to talk about, so I really appreciate the opportunity. And I hope that as you walk away from this, you will have at least some practical advice to help decide what to tell your patients when they're asking you about weight loss surgery. So first of all, my disclosures, I don't have any financial interest or extramural support for this activity. I won't be discussing off-label use of devices or drugs. So our objectives today, what I hope to do is talk about a few things. How big is the obesity problem? Why are we as Americans becoming more and more overweight? What are the barriers to weight loss in those with morbid obesity? What are the indications for surgery for morbid obesity? What are the options for surgical treatment? Why do patients choose a particular procedure? And then what we can do as providers to help advise our patients. And that sounds like a lot, but I think I've got it pretty condensed and it should go relatively painlessly. So first of all, this is a very medicine thing to do. I just was going to present three patients for you, some patient scenarios that you may encounter in your clinic. First, there's Miss G. She is a 51-year-old female with a BMI of 50. She has type 2 diabetes, hypertension, osteoarthritis, and needs knee replacements. She has a past surgical history of a total abdominal hysterectomy and bilateral salpingo oophorectomy and a lap chole. She's married from Roanoke Rapids, and she's a nurse. Miss L is a 29-year-old female with a BMI of 43. She has polycystic ovarian syndrome and asthma. She's had a C-section. She's married from Durham and has a growing family. And finally, Mr. B, a 45-year-old male with a BMI of 68. He's had diabetes for 10 years, hypertension, hyperlipidemia, obstructive sleep apnea, and the list is too long for me to recount here. He's had a spinal fusion from a posterior approach. He's married. He's from Pittsburgh, and he's disabled by his obesity. So just how big is the obesity problem? I think there's no one in this room who doesn't have both a practical and theoretical handle on just how bad the problem is. All of you in your clinics are seeing that a greater and greater proportion of your patients are overweight or obese. But of course, there is data to back that up. Right now, more than 2/3 of adults over 20 in the U.S. Are overweight or obese. So that means they have a BMI of greater than 25. A third of adults greater than 20 years old are obese with a BMI greater than 30, and almost 5% of adults over age 20 are extremely obese with a BMI of greater than 40. I think even more alarming is the growing rate of childhood obesity. So this disease is stretching earlier and earlier into development. And it's just amazing when you see newspaper stories about teenagers that need liver transplants as a result of steatohepatitis. So this is the behavioral risk factor reporting system. This is results from a random digit survey, and so this is self-reported. If you look back in 1990, see if I can get the mouse come up. The cool colors, the white is no data, and the cool colors represent people reporting, less than 10% of people reporting that they have a BMI of greater than 30. In 1995, as the colors grow darker, more and more people are reporting that they have a BMI of greater than 30. And then here in 2005, the darker colors, so down here in the deep south, people are reporting, greater than 30% are reporting that they have a BMI of greater than 30. And so you know that this has to be more. I think what's really telling is how quickly this change has occurred, and we think that the pace of change is accelerating. So in talking about how big the problem of obesity is, I think that we all probably understand that obesity causes significant morbidity. It increases the risk of developing a number of diseases, including diabetes, hypertension, coronary artery disease, non-alcoholic fatty liver disease, and steatohepatitis, obstructive sleep apnea, hyperlipidemia, and the list goes on. And these actually, this list are the ones that I think of when I'm treating people with obesity, of the ones that I'm really going after. And in fact, I'll say this now, and it's going to be valid later on. Surgery for obesity is one of the only procedures that cures multiple diseases at one time, or at least puts them in remission. And I had a proctor come and proctor me on a new band procedure yesterday, a private physician from in Cincinnati. And actually, I thought the way that he talked about this was just perfect. He said you trade multiple chronic medical problems that are difficult to manage for one chronic medical problem that is easier to manage. And that's essentially what I think we're doing when we do surgery for morbid obesity. I really had never heard it put that way before, and I like it a lot. Of course, we all know that obesity has significant mortality. It increases the risk of premature death. We think that it may cause from anywhere between 100,000 and almost 400,000 premature deaths a year, and it will soon overtake, if it hasn't already, overtake smoking as one of the most important preventable causes of death and one of the most expensive medical problems in the U.S. So we think that somewhere around 5 to 7% of our total health care dollars in the U.S. are spent on the morbidly obese. I actually think that number is low. It costs more than any other health problem. And this was it made more sense back when gas was $4 a gallon, but we are probably burning as many as 1 billion more gallons of gas a year because of the increase in weight since 1960. So why are we overweight? As you sit and eat your Bear Rock Cafe that's got and the sodas on the side over there and the bagged potato chips. Really what it comes down to, there are actually, I think, a number of reasons that we've become overweight. Frankly, in our first world country, everything is arrayed against people losing weight, and everything is in favor of people gaining weight. And one of the first things I will talk about is the availability of high-calorie, very inexpensive food. And in fact, this has been in the news lately. I don't know if you've seen this, but they're talking about places where it's inexpensive to eat, like McDonald's and Quiznos and places like that. Those places, their business is booming because nobody can afford to go out and eat in an expensive restaurant right now. And the food in those places, the way I tell my patient this all the time, the way that they make food taste good, the way that restaurants make food taste good is they put lots of sugar and fat in it, and so it tastes good. And it's cheap. We also consume way too much food in terms of portion size, and just before the presentation, Karen was talking with Nilsa about that, and the fact that our portion sizes are so incredibly large. So if you go to Maggiano's and you don't walk out with a grocery bag full of leftovers, you feel like you've been cheated. And whether you realize it or not, the cost of the food, I used to actually work for a restaurant and was a manager for a while, the cost of the food as a proportion of what it costs to run the restaurant is really very small. And so they can give you a sense of value by giving you huge amounts of food that will keep you coming back. And it really doesn't cost them very much more. And so that's what they do. There was a commercial that was on TV a little while back. It was a Visa commercial, and there's this couple, and they're getting ready to go out to eat, and they're getting all dressed up. They go to a little French restaurant, and they get little food, you know, this little plate. They get done eating, they say, wow, I'm hungry, let's go get something to eat. Well, as it turns out, the little food is what we're actually probably supposed to be eating. If you look back in the 50s when Ray Kroc bought McDonald's, what is now a kid's meal was the adult meal back then. So the same size hamburger, the same size fry, the same size drink. And now, you know, of course, you could go to McDonald's, have a supersized meal, and you get your entire caloric intake for the day in one meal, if you're, particularly if you're female. So large portion sizes are a big problem. Next, our sedentary lifestyle. Our communities are actually designed to keep us from exercising. So you can't walk from one place to another on a sidewalk in most big urban areas or suburban areas in America. I mean, there's this little strip that when I go out and walk that I'd love to have a sidewalk so I don't have to walk on the side of the road that would connect my neighborhood to the next neighborhood up the street. And of course, you know, building that's going to cost $100,000 and nobody's going to pay for it. You can't walk into a building that's more than 1 story tall that's a public building and not have access to an upper floor that's powered in some way. You don't have to get up to change the channel on the TV. Kids no longer play games. My kids are, frankly, as much as I know that they should be outside playing, they're victims of this as well. Instead of going out and play tennis, you play tennis on the Wii. Instead of playing football, you watch football. And so all of our entertainments have become very sedentary, or a lot of our entertainments have become very sedentary. And then our work. Work in America, for the most part, requires very little physical activity. Even farmers, I come from a generation of farmers, you think of them as being really hard working, but what do? They drive on a tractor all day. And they have lots of labor-saving devices that allow them to have great output with minimal effort. The Amish, I saw in the paper not too long ago, and I actually meant to look up the study, and I haven't yet, but apparently there's a gene that predisposes to obesity that 30% of Amish have. None of the Amish are obese. Why are they not obese? Because they work all day long, and the work involves physical activity. And so the last thing, of course, is our genetic heritage. There's no question that we, as a species, we're selected to conserve in times of plenty so that we'll be ready for times of famine. And I think you were probably at a disadvantage. You've had the friends that eat all they want, and it seems like they never gain weight and they never really exercise. Well, that person probably wouldn't have survived the famine in days of old, and so they would have been selected against. I think that's true. So what are the barriers to weight loss for the morbidly obese? First of all, I'll say this: diet, exercise, and medications don't work well to a certain point. I kind of have my own beliefs about why this happens, and I think there's this ever downward spiraling cycle that people that are trying to lose weight find themselves in. Get a little overweight, it becomes a little bit uncomfortable to do physical activity, and without even knowing it, it's like a person with claudication. Without even knowing it, you just slowly change your activity level. And before you know it, when you used to park far away from the door at the grocery store and walk in and cruise around the grocery store, all of a sudden you're looking for the very closest parking place and you ride the little cart when you're in there. You don't take the stairs anymore, you don't exercise anymore, you tell your kids you can't play because if you go out there and run around with them, you're going to be short of breath. And so then your muscle mass decreases because you're not getting any exercise, your metabolism goes down, and before you know it, it really takes. So patients tell me all the time, doctor, I really don't eat very much, and they're huge. I mean, they're 400 or 500 pounds. I really don't eat very much, and my weight seems to stay the same. And I say, I believe you. I think that's true, especially women. Women are at a huge disadvantage because you don't have as much muscle mass to support your metabolism, and so they're eating 1,000, 1,200 calories a day, which, remember, is just one supersized meal at McDonald's, and, they maintain their weight. What we have seen in patients, in studies that have looked at patients over a long period of time, such as a Swedish obese subject study, is that people that are treated, morbidly obese people that are treated with medication, diet, and exercise tend to gain weight over time, where people that have had surgery tend to lose weight over time. I'm not saying that that's true for every group of overweight people, but I do think there is probably a tipping point somewhere where you almost reach a point of no return. It becomes so difficult to do anything in terms of physical activity, and your metabolism is so low that it's almost impossible to lose weight. Having said that, I also think that there is something about and as weight loss surgery becomes more and more available, I think it will become less successful. And the reason that I think this is true is, up till now, it has taken a lot of effort to get an operation to lose weight. And as weight loss surgery becomes more available and it becomes easier, I think that the patients will not be as self-selected as they have been up to this point. And so we may find that it doesn't work as well. But up till now, if you wanted a weight loss operation, you really had to work at it. And so most of these people, it's a major turning point in their life. And again, this visiting surgeon said 20% of it's in the device and 80% of it is between the ears. And I think that that's true. What happens is, it's just the little bit extra they need to actually make that transition from gaining or maintaining weight to losing weight. And before you know it, they've lost enough weight that they actually can be physically active again. And that reverses that downward spiral. Referral patterns have not really caught up with the data. There have been some studies done that suggest that primary providers do perceive weight loss surgery as effective, and they do perceive medical therapy as largely ineffective. Even so, most providers rarely refer patients for weight loss surgery. And we'll continue to try these other methods for helping people lose weight. And of course, the insurance companies put up barriers to people having weight loss surgery by requiring them to go through all these things before they'll approve their operation. So what are the criteria for weight loss surgery? It's really pretty simple. First of all, they have to be morbidly obese adults. So that means a BMI of greater than 40, and they don't have to have comorbidities. Having said that, almost everybody I've met with a BMI of 40, unless they've just been overweight for a short period of time, they've developed comorbidities, at least hypertension. Or a BMI of greater than 35 with comorbidities, and it can be any of the ones that I have talked about earlier. They have to have failed attempts at non-operative weight loss, supervised diet, exercise, behavior modification, and drugs. And so when you send patients to us and we ask for these records and say that they have to have gone through this, if you were asking me personally, I would say I would have hoped that they had tried to lose weight with some non-surgical therapy before, but most of these people will come to you and they say, I've been heavy for 20 years and nothing I've ever done has worked, and it's probably true that weight loss surgery is the only thing that can help them. So, but if you wonder why we asked for all this stuff, there was these guys that got together in a room back in 1991, and there was an NIH consensus panel that was convened, and they just said, without really basing it in data, that these were going to be the numbers. And so now, of course, people that pay for the operation use these as hurdles or barriers to people getting paid for reimbursement to have the operation. So they have to be motivated and well-informed. Of course, if the patient can't make decisions for themselves, I'm hesitant to operate on them. And so that's where you start getting into problems operating on children or adolescents. The parents are basically deciding for the child that for instance, if they have gastric bypass, that we're going to rearrange their gastrointestinal anatomy for them for the rest of their lives. And I'm not so sure that the children, I'm not so sure that's fair to them. So for now, weight loss surgery in those people shouldn't be done outside of study centers or specialty centers, and I don't do it. I may help if Dr. Helmreth decides to start doing it here at UNC. I'm happy to help him, but thank God he's willing to take on the task of dealing with them after they've been operated on. They have to be free of significant psychiatric disease, and all of our patients undergo a psychiatric evaluation. If you were to ask me, do I think has it made a difference in terms of, has it caused me not to operate on somebody yet? I think the answer is no. There has been one patient that I've refused to operate on because I'm like, she wanted to have a lap band, and we'll talk a little bit about this, more about this later, but that means I'm going to have to see her for every 6 weeks for the next several years. I'm like, there's no way. You and I are not going to be able to have a relationship that extends that long and be successful at it. And it was because she was she was tough. And I actually have thought about studying this myself and asking bariatric surgeons, how often does the psychiatric evaluation change your plan of care? And I think most of them would say almost never. But if they do have psychiatric disease, all we require is that it be well treated and well compensated. Finally, the benefits of operating need to outweigh the risks. So if they have chronic medical conditions that are not well treated, then we basically say you need to have your chronic medical conditions well treated before surgery, whether it be COPD, CHF, reversible coronary artery disease. There are some things that they're probably not going to reverse, and we may say that it's just too risky for you. And a good example of that would be somebody with cirrhosis and end-stage liver disease. So what are the options for surgical treatment? Most of you probably have heard this, but I'll go over it for you one more time. There's Roux-en-Y gastric bypass, which is the most commonly performed procedure in the U.S., probably somewhere around 80% of procedures, both by the laparoscopic and open approaches. I will tell you that we're doing study of NIH data right now, and it's being presented in abstract form and will hopefully soon be published, that says we really actually don't know how many procedures are being done in the U.S. right now, and we don't know what proportion is gastric bypass and what proportion is laparoscopic adjustable gastric band. The problem with it is the manufacturers won't give us the number of devices they're selling, and they say it's proprietary data. They gave it to us by mistake, but we couldn't use it because they wouldn't give us permission. they sent us, it was really kind of funny, they sent us an email that had a PowerPoint slide on it, and if you went into the PowerPoint slide and pulled out the data from the charts, you had the data, but they wouldn't let us use it. And also, another problem is that the codes, most of the way we try to figure out how many of these procedures are being done, there is no central database that we all report to, like an outcomes database or anything like that. And so we try to basically get it from administrative data. Well, up until just a couple of years ago, there weren't codes for a lot of these operations, so you have to come up with these coding algorithms to try to capture as many cases as you can. But anyway, we think that Roux-en-Y gastric bypass is the most common. Laparoscopic adjustable gastric band is the second most common, taking up somewhere between 20 and 25% of cases. And then there are other procedures that are being done much less frequently, such as biliary pancreatic diversion and sleeve gastrectomy. Older procedures are still being done, which is hard for me to understand, such as vertical banded gastroplasty. And there are emerging technologies that are being tried, such as intragastric balloon placement by endoscopy, duodenal condoms, so you put a sleeve that goes down through the first part of the small intestine and essentially, for all intents and purposes, bypasses the first part of the intestine. And you can imagine what some of the problems in terms of device failures and obstructions and things like that that can occur. So this is just a quick diagram of the procedures that I just talked about. Gastric bypass here, we make a small pouch. A lot of people ask what happens to the stomach. It stays in. The pouch is completely divided from the stomach. And why do we leave the stomach in? It would be a much bigger operation to take it out. And there's probably, there's intrinsic factor. And so, I don't know, there's some reasons to keep it in, and maybe some activation of enzymes from gastric acid and things like that. But basically what we do is we divide the intestine just distal to the ligament of Treitz, and we attach that up to the pouch, and then we plug the bile and pancreatic juices further down on the jejunum. This is the jejunostomy. So whereas before your food came into your stomach and then out into your small intestine and was digested by that common channel, now your food comes into the pouch, and this pouch is small. The anastomosis is small, so food doesn't go through the pouch very well, so it's both restrictive. And then because we bypassed parts of the small intestine in terms of absorption, remember, as the food comes down this, it's not being absorbed because it hasn't mixed with the biliary and pancreatic secretions from the liver and the pancreas yet. And so it mixes here, and then the rest of the small intestine is involved in absorption of macro and micronutrients. We don't know why, but this procedure, bypassing the duodenum, also cures type 2 diabetes, or I shouldn't say cure, that's the wrong way of saying it. It helps type 2 diabetes go into a remission for the majority of patients within weeks of surgery, even before they lose the weight. The other thing that helps people lose weight besides the restriction and the malabsorption is they get dumping syndrome. If they eat foods that have lots of sugar or drink drinks with lots of sugar, then the sudden release of insulin caused by all this sugar in the small intestine causes release of glucagon and adrenaline, and they get palpitations, and the osmotic effect of all the sugar in the small intestine causes diarrhea later on. So they get dumping syndrome, and that keeps them from taking foods and drinks with lots of sugar. Next, the adjustable gastric band. Karen actually has an example of a real device that we're placing in patients in a model stomach that we can pass around the room. The band goes up near the gastroesophageal junction. It makes a very small pouch. This band is adjustable so that the stoma from the upper gastric pouch to the lower can be changed in size to provide adequate restriction, which is a big change from the vertical banded gastroplasty of days gone by, where the pouch size and the stoma size were fixed by the size of the band. So the way this procedure works, this is a purely restrictive procedure. The way we think it works, and there are studies to support this, is that it makes people feel full. So when food sits up here near the gastroesophageal junction, you eat, you feel full faster, you stay full longer because it doesn't empty very well, and those two things together help control your appetite. With the band properly adjusted, people will tell you that they basically lose their interest in food. And there was actually a advertising campaign that was based on the idea of early satiety, the taming the tiger into the little kitten, the lap band. You may have seen that on TV a year ago or so. And there is, as I say, some studies to suggest that that is actually the way it works. So I think that that's more important than the idea that if you eat too much, the food regurgitates, or that you just can't get it down. Finally, there's the duodenal switch. This is a big operation. And basically what we do is divide the small bowel right distal to the pylorus, and we plug the biliopancreatic limb in very close to the ileocecal valve on the terminal ileum. This distance is usually about 100 centimeters, so there's a very short common channel. A lot of people will divide the stomach, tubularize the stomach, and then the pylorus remains intact. Food comes down this limb and doesn't mix with biliopancreatic secretions until it gets here, and there's a short common channel for the absorption of micro and macronutrients. So you can imagine this is mostly malabsorptive. There's a little bit of restriction with the smaller stomach that doesn't have the expanding greater curve. But as you can imagine, there's lots more malnutrition with this operation. Why is this different from the jejunal ileal bypass of old that Dr. Gangross and I were just talking about prior to the conference? Well, it used to be that they didn't do the duodenal switch, and they just basically plug the small bowel in right next to the ileum. And so you would eat, the food would come down here, it had this little bit of length to absorb, and then you'd have a bowel movement within 30 minutes of eating. The difference is that both of these limbs are functional. There was a defunctionalized limb in the jejunal ileal bypass, and this one there's not. So this operation, we don't perform it here, and some of the things that I say later may suggest we do, but the two that we do at this institution are gastric bypass, adjustable gastric band, and revisions. So why do patients choose a procedure? So when a patient comes to me and they say, I want gastric bypass, or they say, I want a gastric band, I say, okay. First of all, and I'll get to why that is here in just a minute. First of all, there's personal research. There's a very well-developed online community among people that have weight loss surgery, particularly the gastric band. There's a surgeon in Louisville, an academic surgeon who's done thousands of bands and teaches about the band, and people know when he's going out of town. They'll be typing away at their computers and they'll say, Dr. Allen's going to be out of town this week, so I hope you don't need him. They know his schedule probably better than his secretary does. Family or friends may have good or bad stories to tell. You and I know that anecdotal evidence doesn't have anything to do with what happens to a patient, but of course they think it does. There's direct-to-consumer marketing, as I talked about before, and it can be pretty aggressive. So that's one of the reasons that the band is becoming more popular as time goes on in America. There's perceived risk and perceived efficacy. Some people have skewed views of how risky or good or bad an operation is. There's the availability of a procedure in the community. Some places don't do gastric bypass. The only thing there is the band, or vice versa. Some places don't do laparoscopic approaches to surgery. They may base their decision in part on their primary care provider's advice, and whether or not that person knows what they're talking about probably doesn't matter. There's a preference for a surgeon and a surgeon's preference. You know, surgeons may get very locked into one particular way of doing things, and the patient may have developed a good relationship with that surgeon, and if the surgeon says, you know, the only thing I do is gastric bypass as an open procedure, the patient may say, that's fine with me, doc, let's go. And I think that's actually probably valid. I'd probably rather get gastric bypass by open operation from a surgeon I like than laparoscopic adjustable gastric band from someone that I don't care for. Finally, there's cost or insurance coverage for a preferred procedure. As you all know, there is no universal coverage for or standards for coverage for any of this stuff. Some insurance companies make it harder to get one procedure or the other, or they don't cover one procedure or the other, or in some groups and not other groups, and so that may be a reason they decide. In terms of the patient education and informed consent, you have to ask yourself, well, do the patients really understand what they're told? There's been recent studies that have suggested that health literacy in North Carolina is very poor, and as many as half of North Carolina adults have low health literacy. The discussions of the risk, the benefits, and the procedures themselves are very complex. I have a hard time for some of these things, getting medical students to understand it. So what about a person that has, you know, an 8th grade education and has no understanding at all of anatomy or physiology? Do patients remember what they're told? So bariatric surgery patients have been shown to have a poor recall of the risk and benefits when asked later after we've gone through the informed consent. We know that a great deal of medical information is forgotten almost immediately, and of the information that's remembered, a lot of it will be incorrect. Should patients believe what they're told? Again, current data does not support estimates of outcomes on an individual basis. When I tell patients that your risk of having a postoperative complication is X%, what I'm really telling them, as you all know, is that if you look at 1,000 patients that have this operation, this number of those patients, 40 out of 100, 40 out of 1,000 will have this complication. And if you look at what studies have been done comparing different types of operations, it really is very difficult to say with any certainty that one is better than another in an individual patient. And then, as I said, there may be some pretty extreme surgeon bias out there, and surgeons may steer patients in one direction or another for whatever reason. So let's get back to our patients, Miss G, Miss L, and Miss B. So how should we advise our patients? First of all, laparoscopic room-wide gastric bypass, adjustable gastric banding, biliopancreatic diversion, and duodenal switch have all been proven effective as nearly as they can be. And we can talk about that some more later if you want to. And I'm not saying our data is perfect, it's not, but it's the best we've got. And I think that all of you know on a very visceral level that we're not doing a good job of treating obese people outside of surgery. There's a paucity of randomized controlled trial comparing the different bariatric procedures, and I would even say that some of that becomes out of date very quickly as devices come on the market and are changed. So, the device that we're using now, the laparoscopic adjustable gastric band we're using now, is very different from the one that was introduced in 1993, and some of the studies that were done, randomized controlled trials on band and bypass, were on the old device. And everything has evolved. The techniques for placing the band, the techniques for doing gastric bypass, and I would say we're actually getting better as time goes on, but that means that some of the data we collected before may not really apply anymore. Finally, decisions are driven by patient and surgeon preferences, and a lot of people will consider things outside of the simple nuts and bolts of the operation itself in terms of outcomes, risk, and lifestyle changes. So I think it's useful to at least do a quick little, give you just a little information about how these operations work. If you're looking strictly at weight loss, biliopancreatic diversion and duodenal switch works the best. At 10 years, people have maintained a 77% excess weight loss. So what does that mean? If a person weighs 300 pounds, their ideal body weight is 150 pounds, and they lose 50% of that, then they've lost 75 pounds. Basically, that's 50% excess weight loss, which is what you would see down here with adjustable gastric banding. With room-wide gastric bypass, we're talking about 50% at 10 years. This number that shows 60% at 10 years in adjustable gastric band, there's only been one study with a very small number of patients, and half of those people had their band removed at that time. And so I tell patients very honestly when they come to see me and talk about adjustable gastric band, I really don't know what it's going to be like for you 20 years down the road. Will you still have the band? I don't know. I know this, if I take it out, you're probably going to gain weight again. But I tell my patients this too. I think hopefully in the next 20 years we will have gotten medical treatment of morbid obesity worked out to the point that my twilight as a surgeon will be taking gastric bands out of people. In terms of improvements of comorbidities from the big list that I talked about earlier, when you do a band, about 50% of people will have their diabetes improve or go into complete remission. With Roux-en-Y gastric bypass, that number is 83%, almost 84% with biliopancreatic diversion. It's amazing. It's almost 100%. And you can see similar improvements in hypercholesterolemia, hypertension, and sleep apnea. The mortality of these procedures, the least morbid procedure is the gastric band, which has a very low perioperative complication rate and a relatively low overall complication rate. The other thing I'll tell patients about this operation is that the complications are usually not life-threatening. They're usually device-related. They're usually relatively easily treated. Even if it does require an operation, it's usually not a huge operation. And you can see the major complication rate is very low. I think as years go by and people have these in for 20 or 30 years, the problems that we see with slips and erosions and things like that are going to become more frequent. In terms of laparoscopic room-wide gastric bypass, the 30-day mortality is somewhere between 0.3 and 1%, overall complication rate around 20%, major complications around 2%, and for duodenal switch, it's fairly similar. So this is a relative risk scale, risk and benefit scale for the operations that I just mentioned, but my fellow came up with this algorithm, which I thought was really nice. So you look at what's most important to the patient. Is it the best weight loss, the lowest risk, the most convenient follow-up, or the best comorbidity resolution? And then among each of these, you can kind of decide who the winners are among the procedures. So in terms of lowest risk, the gastric band wins, and the biliopancreatic diversion loses, and the Roux-en-Y gastric bypass is somewhere in the middle. And if you look at all these triangles, the Roux-en-Y gastric bypass falls in the middle, which is probably why we do a lot of gastric bypasses in this country. In almost all of these, it's kind of the best of both worlds. In terms of technical complications, gastric band wins early, but then falls to the bottom in terms of late complications. Metabolic complications, the band wins because we're not rearranging the gastrointestinal tract. We're not causing any malabsorption. If you're looking for the most convenient follow-up, biliopancreatic diversion in terms of durability and poor compliance is going to be the best. If you don't come back and see me with a gastric band, you're not going to lose weight because it has to be adjusted. The lowest need for frequent outpatient visits, Roux-en-Y gastric band or Roux-en-Y gastric bypass wins. Biliopancreatic diversion is next, and then the adjustable gastric band. Again, you're going to have to see me frequently if you have that procedure done. And in terms of best comorbidity resolution, the most radical procedure does the best job. The least radical procedure does the worst job. So going on to our patients, Miss G, 51-year-old female with a BMI of 50, diabetes, needs a knee replacement. She's married from Roanoke Rapids. She's a nurse. Has had a relatively uncomplicated abdominal surgical history. So she's willing to accept the morbidity and mortality risk. She has a significant amount of weight that she needs to lose quickly so that her orthopedic surgeon will do the procedure for her. Her comorbidities include diabetes, which, as I said, she has a much greater chance of having her diabetes resolve or go into remission with laparoscopic gastric bypass than she does with the band. She's past her reproductive age, so she's not so worried about the malabsorptive part of the procedure. She's willing to accept the dumping syndrome. She understands that the procedure is irreversible. She lives far away. She needs less follow-up to assist in her weight loss. Miss L, on the other hand, still a young woman, still has a growing family, lives close by. So she wants the procedure that has the lowest risk of morbidity and mortality. She has less weight to lose. She has fewer comorbidities and no diabetes. She plans to have children, so it's good for her that this procedure won't cause any malabsorption. And actually, during pregnancy, if she begins to have nausea and vomiting, we can always take all the fluid out of the band. If she needs to gain weight, just take all the fluid out of the band and she should do fine. It's most easily reversible if she ever decides to have it out and it doesn't rearrange the GI tract. She's willing to accept the possible device complications. She lives close by and she thinks that coming to see me every 6 weeks will actually help her in her weight loss. Finally, Mr. B, again, we don't do biliopancreatic diversion duodenal switch here, but if we did, he would be the perfect patient for that. Significant comorbidities of long-standing duration. He's willing to accept the higher risk of mortality and morbidity because he knows that his weight is going to kill him if he doesn't change something soon. And his included comorbidity of diabetes will respond well to this operation. He's willing to accept the risk of malabsorption and the fact that we may have to do an operation at some time in the future to reverse that. And he lives close by and understands the need for close follow-up. So hopefully, you know, after our short time together, I've helped you with a few things. As you all know, obesity is an enormous and growing problem. I think that there are lots of factors that contribute to morbid obesity in America. I do believe that medical therapy in select patients, those that are very heavy, really doesn't work well, and that surgery is the only reliable answer to them losing weight. I think that there are lots of options for surgical treatment, and that in large part, what the patient prefers will drive us to decide which one they should have. Having said that, even though there's no randomized controlled trial evidence, I think, or I shouldn't say no, it's just not very good. I do think that there, as I talked about, are certain patients that may benefit more or less from the different procedures. I'd be happy to take any questions. Yes, sir.
Could you describe a little bit more the gastric band device itself and how it's adjusted? Does it require surgery? Or is it a reduction complication that it's called?
Sure. So the band will come around to you in a little bit. It has a little port that attaches to a piece of tubing, and there's an inflatable balloon that is that you can blow up, and that decreases the stoma size. That port is just like a portacath port. In fact, the first ones were from portacaths, and so you access it with a Huber needle through the skin, and you just push a little saline in there, and that makes the stoma size smaller from the upper pouch to the lower. And what we do is we try to get patients, we call it, well, the manufacturer calls it the green zone. And what you want to do is, your goal is to have the patient losing 1 to 2 pounds per week, tolerating a wide variety of foods, and not having any symptoms that the band is too tight, such as reflux at night and things like that. In terms of the infectious complications, actually the band doesn't seem to get infected. If we do see patients that have, so we'll have a patient that's a year or two out, all of a sudden the incision over the port becomes infected, that always means that the band is eroded into the stomach or the esophagus. And so actually in terms of infecting the device itself, it seems to happen almost never. Yes?
I'm in the nutrition clinic, and we have right now our protocol that do transplant help people whose BMIs are over 40. So I put these people on the transplant list, they sit and they wait, and they never lose weight. How do you feel about these procedures in dialysis patients? And I think that this is what we're going to have to go to get these people to transplant, which will also significantly increase their mortality or decrease mortality.
You know, I think that is a really tricky question, and there's lots of reasons why. I wonder, you know, these operations are going to have potentially gastric bypass, significant nutritional changes and fluid intake changes and things like that. And with gastric band, for instance, if they've had peritoneal dialysis before, for instance, they may be very difficult to operate on. Maybe less in terms of nutritional deficiencies than you would see with Roux-en-Y gastric bypass. But the thing that really probably concerns me even more is I tell people all the time, I don't think that people lose weight well with these procedures. I tell them it's a tool, it's not a cure. And if you can't fully participate, both in terms of your diet and in terms of physical activity, you're probably not going to be successful. It's probably worth trying, and I would probably, as these people probably have other comorbidities that make them more ill, I'd probably lean more towards the band than the bypass. But I think it's a tricky question. Yes, sir.
The only day we see people who develop after bypass these complex autoimmune reactions, we call them lupus, and they take the procedure down to do things better. We don't see that now.
I can't say that I really know very much about that. I think you may be thinking about the jejunal ileal bypass, which Dr. Gangross and I were talking about before, and I think there were reports of things like that. But in the modern versions of gastric bypass, I've not heard of that as a complication.
So the modern version, we get rid of these autoimmune it's really important to investigate the inflammatory milieu in the body. Because the other thing we're also seeing is that in COPD and asthma, the obese patients is much, much worse. And it likely has to do with the
Well, there is almost certainly a pro-inflammatory state in people that are morbidly obese, which contributes to the development of coronary artery disease. And it's all interrelated. And I think that the modern versions of gastric bypass tend to make those things better as they lose weight. Getting rid of the excess central obesity, the excess central adipose tissue really seems to make a lot of that stuff better. And so I am not familiar with that as a complication in modern gastric bypass.
In the past, I also had a very well connected lady got close for care who came here to see me to COPD and radiation gone off. And me, I'm not well over 40, and I agreed she couldn't get the procedure elsewhere, but I agreed to be with pulmonologist carry out at another institution. And she got, they wouldn't, as you point out, wouldn't do the operation unless she went through all these loops. And and then somebody put her on a weight loss pill that was also carbonic anhydrase inhibitor. And the woman ended up not being able to deal with the CO2 retention and died actually right a day or two the intensive care unit. So I'm just wondering, when you have these people with sleep apnea and lung complications, are people aware of the importance of the carbonic anhydrase inhibitor and maybe some of the drugs they use that I'm not very familiar with?
Yeah, I can't say that I've heard of that either. I actually have relatively little to do. I mean, I've read some, but relatively little to do with the drugs. Usually the people come to me and they say, oh, they didn't work, and then they say, well, let's talk about an operation. But I can't say that. I know much more about the sort of perioperative complications with regard to pulmonary problems than I do the drugs that might affect them. Yes, ma'am. Or whoever.
I've seen some studies that suggest weight regain 15 or 20 years postoperatively, even after the Berlin live. And I just wonder if you have a comment on that, and then also recurrence of diabetes. Your diet.
Absolutely. So what I think happens is that people's bodies, and I tell my patients this, I'm like, your golden opportunity to lose weight after a Roux-en-Y gastric bypass is the first year to 18 months. And after that, your weight's going to plateau and you're probably going to gain some back. And what happens is the body adjusts to its new configuration, and so the common channel will become more efficient at absorbing micro and macronutrients, and the pouch will stretch a little bit, the stoma will stretch a little bit, that alimentary limb will become a little more accommodating, and so eventually they're able to eat more and absorb more in terms of their calories, and then maybe they're not quite so motivated and they don't exercise as much. And so yes, that is true, the weight goes up, but usually the weight loss is enough and is persistent enough that it does help them. 20 years without diabetes is huge, in terms of developing comorbidities, so that's a success as far as I'm concerned. And the same thing I would say, we're beginning to believe that people that have long-standing diabetes or are on insulin are less likely to have resolution of their, or remission of their diabetes after gastric bypass. But if you get them off insulin, you get them onto one single oral medication a day, again, that's success to me. And so what you say is true, but I think that there have certainly been studies that suggest that mortality goes down for these people if you intervene early enough. If you wait and intervene when they're 70 years old and they have lots of problems, then you probably don't have enough time to see the positive result. But if you intervene early enough, then you can help them.
What about biliary stones after weight cut?
So that is a problem. If untreated after Roux-en-Y gastric bypass during the period of massive weight loss in the first 6 months to a year, as many as 30% of people will develop gallstones. If you treat them with cholestyramine, it drops to more like 2% or 3%. And then, of course, a relatively small percentage of those people will become symptomatic. And so as a part of our protocol, we treat people to try to prevent the formation of gallstones. Well, it sounds like that's it. Thank you very much.